Welcome everyone to today's seminar. I'm Suzanne Judd, Director of the Lister Hill Center for Health Policy. I'm very excited to welcome you to today's webinar. This blends a part of what I do with my research life, which is cohort study work, with what we're doing here at the center, studying LGBTQ plus health issues as we discuss the PRIDE study today. But before I introduce our speaker, I would like to point out a few things on your screen. The webinar is available in listen-only mode. Please use the Q&A box at the bottom of your Zoom window to submit questions for our speaker. The speaker will answer questions after the presentation. Additionally, we are providing live captioning for this event, which can be enabled through the bottom menu as well. If you experience any technical issues, this webinar will be recorded and it will be posted on the sponsors' websites for future viewing. And now it is my pleasure to introduce our speaker for today. Kristen Clark is a PhD candidate in nursing at the University of California, San Francisco, and a member of the PRIDE study research team. Her doctoral research is centered on the structural barriers to healthcare access, healthcare experiences, and symptom experiences of transgender and gender expansive people in the United States. Her doctoral work is funded through the National Institute for Nursing Research Predoctoral Fellowship, NF31. Prior to pursuing her PhD, Kristen worked clinically as a nurse in inpatient mental health, specializing in crisis stabilization care. In this capacity, she worked to advocate for more inclusive and knowledgeable mental health care for transgender people through improved hospital policies, state-level policy advocacy, and to increase LGBTQ plus educational content in Florida nursing schools. Please join me in welcoming Kristen Clark today.
Thank you so much for having me. I'm excited to be here today and speak to you all about the PRIDE study. As you can see here, the PRIDE study is not just a term of relevance to the LGBTQ plus community, but it's also an acronym for our study, the Population Research in Identity and Disparities for Equality study. Everything we do in the PRIDE study centers on one foundational question: how does being a sexual or gender minority person influence physical, mental, and social health? This is the first talk you've heard about this population, so I won't go into too much detail here. But just as an overview, when we're talking about the PRIDE population, we're talking about a wide range of identities. People may describe their sexual orientation as lesbian, gay, bisexual, or queer. People may describe their gender identity as transgender or queer. Participants may also choose another term to describe their sexual orientation and/or gender identity. The PRIDE study was designed as a national, online, prospective, longitudinal cohort study. There are some basic requirements for inclusion in the PRIDE study. Participants should identify as a sexual and/or gender minority person. They must be 18 years of age or older, and they need to reside in the United States or its territories. Surveys are currently only available in English, so participants needed to feel comfortable reading and writing in English. Several rationales underline the decision to ground the PRIDE study as an online study. First, digital interactions, such as with a website or a mobile app, can be free from stigmatizing or discriminating in interpersonal interactions, such as the homophobia or transphobia that participants may experience while engaging with research. We also know that fear or the anticipation of experiencing those stigmatizing or discriminatory interactions can impact participation in research. Online platforms help to remove those barriers. Second, the ubiquity of internet access from numerous devices such as computers, tablets, or smartphones enables a broad reach into geographical areas away from traditional research centers. This allows for greater outreach to rural communities and less urban towns where sexual and gender minority people may reside, but have been less represented in research. Thirdly, customization allows unique experiences composed of study components applicable to specific participations, such as tailored survey language and questions based on demographics from the participants or reported behaviors that the participants engage in. For example, a transgender woman who is bisexual can choose to answer survey questions that are specific to her sexual orientation, specific to her gender identity, or she could choose to answer both sets of questions. The use of an online platform also permits study participants to consent to sharing very specific aspects of their participation and designating who can receive those data. Fourth, the participant remains in full control of their participation and can easily determine the specific study components that they would like to perform without the pressure of an in-person interaction. During that in-person interaction, they may feel obligated to maintain participation or embarrassed to refuse specific study components that may be uncomfortable for them. If a participant does not feel comfortable answering any questions, for example, about substance use, they can skip them and choose not to engage without feeling that they are being looked down upon for not answering those questions. In person, that decision may feel loaded and emotional. Finally, digital approaches can be rapidly modified as needs dictate. Some reasons may include societal changes and in response to participant feedback. Considerable work has been done to ensure that the language used in the Pride study reflects community norms and preferences, but these are fluid and can change. Digital platforms accommodate these changes well. In the Pride study, the participant is central to the design and framing of the study. We aim to ensure the study is low burden. Once a participant enrolls in the Pride study, Pride Study's online platform, they fill out the initial survey questionnaire. We pilot and test the surveys to ensure they are clearly worded and require a limited amount of time for participation. Participants are not required to complete any specific number of surveys to stay engaged. Their participation is entirely dependent on their time, availability, and desire to engage. This is also related to our commitment to make sure that the study is easily accessible. The Pride Study staff are ready and available to help participants with any difficulties that they encounter. This includes feedback on their survey experience. We welcome that at any point in time during the participants' engagement with the Pride Study. We also require that any publications that come from the data in the Pride Study are made open access so that participants can see the results of their data contributions. We believe that our participants know what's best. This means that we engage in community members during survey design, and we also center their feedback on the experiences with the Pride Study to guide changes and alterations for a better experience. We also derive research plans from participant input. We want participants to feel engaged and a part of the SGM community through the Pride Study from the beginning to the end. Part of this is accomplished through giving back to the sexual and gender minority community. We hold events for participants and any community members for social engagement and learning opportunities. Recently, we held an event that educated community members on how to engage with scientific research, policy education, and panels that discuss recent research findings and their relevance to sexual and gender minority communities. The purpose of the Pride study really was derived from a call for action that arrived in 2011. In 2011, the National Institute of Health requested that the Institute of Medicine, which is currently known as the National Academy of Medicine, conduct a report on what we know about the health of sexual and gender minority people. This report found that the lack of population-based data presents the greatest challenge to describing the health status and health-related needs of LGBT people. In fact, this is a persistent issue that hasn't been resolved since this 2011 report. Sexual orientation and gender identity, you may also hear this referred to as SOGI data, are still not routinely collected in all federally conducted surveys. One of the best known population-based data sets we have is the Behavioral Risk Factor Surveillance Survey. This survey collects SOGI data, but only in an optional module that states can choose to include. But all use is rising. Up to 35 states include the SOGI model in 2017. Initially, it was far less than this. So we don't have a long period of time of data that of data sets that collect this data on a federal population-based level, but this is starting to improve. This is one survey though, and SOGI data collection is still not the norm. What we know from this 2011 report and subsequent research is that sexual and gender minority people are historically underserved, understudied, and have known disparities in health outcomes and healthcare access. The Pride study helps to bridge this gap as a longitudinal cohort study of specifically sexual and gender minority people in the United States. Now the Pride study works with over 21,000 participants. On our core surveys that are conducted annually, we ask participants about a wide range of health topics. These include physical health, mental health, and their social health. health. We understand that a holistic approach is how we can drive the science forward to improve the health of SGM communities. However, we do have opportunities in the PRIDE study for ancillary studies. So this is just a flowchart of that process, but ancillary studies can be a request to use annual survey data to answer some submitted research questions, or an ancillary study can be a request to send new survey questions or qualitative data collection to participants who are registered in the PRIDE study. Every study goes through the process that's illustrated here. Prospective investigators submit an ancillary study application where they describe the scientific merits of the study that they are proposing, any variables or measures that they want to include if they are proposing a new data collection, and they describe a detailed plan for community level interests. For example, what is the relevance of this proposed study for sexual and gender minority people? How have sexual and gender minority communities informed your research questions? And how are you going to disseminate your findings from this proposed study to the sexual and gender minority community? This application is then sent for a research advisory committee review. This group is comprised of established sexual and gender minority health researchers. Sometimes an application is rejected. Frequently, there are requested revisions to the application to meet the standards of the PRIDE study. These revisions are reviewed again by the Research Advisory Committee, and if approved, it moves to the Participant Advisory Committee. This committee is comprised of a group of sexual and gender minority community organizations. This committee may also choose to reject an application or request revisions. Once revised and approved, it moves forward to the rest of the process, including finalization, implementation planning, IRB modifications, and data collection as applicable, including data transfer agreements and so on. You can see here an image of how we screen participants upon enrollment into the PRIDE study. You can see the next steps in screening are the informed consent process and privacy disclosures and selections. PrideNet is an important part of the PRIDE study. We think of the PRIDE study as the how do we collect data and how do we gather information, but the PrideNet is the who behind this important survey design. It's a national network of individuals and organizations that actively engage our community in every stage of how LGBTQ health research is created, analyzed, and shared from the PRIDE study. PrideNet was developed through funding from Cohort. This allowed the PRIDE study to meet some objectives. It allowed the PRIDE study to create ways to involve patients, families, and caregivers in decision-making about the network, create a way to collect and share data reported by patients for research, involve patients, caregivers, families, and communities in the research process, including recruiting people to take part in research studies. To say it more simply, the PrideNet is a network of people that supports the PRIDE study. PrideNet also supports the National Institute of Health Study All of Us research program and may also participate in supporting other research studies in the future as well. The PrideNet network consists of research study participants, participant advisory committee that we discussed previously in the process of having an ancillary study approved, PrideNet ambassadors, and a consortium of partners and community organizations. Together, they support the PRIDE study by increasing awareness of the study, connecting to LGBTQ+ communities, and therefore increasing motivation to participate via the principles of community engagement, such as trust, follow through, transparency, reciprocal relationships, and making sure there's a low burden of participants to engage. And I mentioned the term community engaged. And so what does it really mean to be in community engaged research? Because the PRIDE study is considered community engaged research. This is defined as a process of working collaboratively with groups of people affiliated by geographic proximity, special interests, or similar situations with respect to issues affecting their well-being. What this means is that through networking, coordination, partnering, and collaboration with community members and organizations, we are moving away from a transactional research design to a participant research relationship where something transformational or a perspective of let's create something new and better together occurs. Sexual and gender minority community engagement through PrideNet helps build trust and fosters a positive bi-directional relationship with participants, community organizations, and researchers as a truly collaborative partnership. Overall, the Pride study is committed to being accessible and widely engaging with our participants through these main principles. We want participants and those working in the Pride study to feel emotionally connected and like active members of the team working towards a common goal of improving sexual and gender minority health. We want participants to be aware of what is happening with their data and to feel like an important part of the work being done. We believe that these are important to help folks continue to feel motivated to continue participation as part of a longitudinal component of the study. We also feel that these emotions can be fostered by ensuring we adhere to some key principles, including trust and follow through, transparency, ensuring there is a reciprocal relationship. And what we mean by this is that we don't just ask for their data, but we also give participants a value in return, and also holding the standard of low burden of participation. Just as an overview, I thought I could give you some examples of work that has come from and contributed towards the development of the Pride study. This study was a survey sent to mental health providers to query what mental health outcomes were most important to their care provision for sexual and gender minority patients. This mixed method study helped guide the mental health outcomes that were included in the initial design and continued design of the surveys. This is one of our foundational papers. When the Pride study was first piloted, it was solely an iPhone app. This publication by Dr. Lunn and others on the Pride study team described the first phase of the Pride study, and we were able to gather research priorities directly from sexual and gender minority community members. At this phase in the study, just over 16,000 participants provided data, and 98% of whom described themselves as sexual minority individuals, and 15% of those participants were gender minority individuals. In this follow-up manuscript, the Pride study team describes results from phase 2 of the Pride study, the launching of the larger digital platform. Over the course of 2 years, over 13,000 people were recruited and retained, of whom almost 33% were gender minority participants. And when we look at the broader population of the SGM community, gender minority individuals comprise 6% of the population. So we were able to recruit a really diverse gender identities in the sample. As I mentioned previously, community input is incredibly important for how the Pride study is designed. To ensure that language used in surveys is inclusive and comfortable for people, a survey was conducted to assess sexual and reproductive health experiences for gender minority people who were assigned female at birth. Language around sexual reproductive health is widely heteronormative and centered on cisgendered bodies. By that, I mean in healthcare, everyone is assumed to be having heterosexual sex. It is also assumed that someone who is assigned a specific sex at birth is comfortable with the language around those primary and secondary sexual characteristics. We know that no, not everyone is heterosexual. And for some gender minority people, the language around primary and secondary sexual characteristics can be uncomfortable or triggering. This study assessed preferences for language and piloted a survey with customizable language that was implemented throughout the survey. What we mean by this is if someone established preferred term for breast, such as chest, any reference to that part of the anatomy through the rest of the survey was changed for their comfort and respect. Another study that came out was testing eating disorder examination questionnaires among the Pride study sample of cisgender lesbian women to describe their attitudes regarding eating disorders and disordered eating behaviors. Previously, there had not been any literature that examined the descriptive characteristics of this measure with this population. They found that 14% of lesbian cisgender participants reported any dietary restriction and 10% reported any binge episodes, but there was a low prevalence of purging in the sample. So this was an important contribution to understanding disordered eating behaviors and attitudes in this population. In the literature, there's been a critical gap in understanding how sexual orientation and gender minority and gender identity questions affect the inclusion and accurate representation of SGM communities. This qualitative study was intended to answer the question, for sexual and gender minority people, what are major limitations with current SOGI or sexual orientation and gender identity questions? These focus groups were probed for reactions to using SOGI questions adapted from prior national surveys and clinical best practice guidelines. Questions were refined and given in semi-structured cognitive interviews, and an analysis was done with 74 participants. Two important themes that were derived were SOGI questions did not allow for identity fluidity, complexity, reduce the inclusion and representation of sexual and gender minority people. And sexual orientation and gender identity question stems and answer choices were often not clear as to which sexual orientation and gender identity dimension was being assessed. What this means is that frequently in surveys, sexual orientation and gender identity can sound conflated. So this paper was really an important contribution because sexual orientation and gender identity question stems have become a standard practice. So understanding better how this is being received among sexual and gender minority people was an important aspect to examine. This study is currently under review, but as mentioned previously, my primary interests are around measurement and structural and social barriers to health and health outcomes that are associated. In the study, we looked at policy environments as measured by state-level policy tallies from the Movement Advancement Project. Just briefly, the Movement Advancement Project measures how protective or harmful a state's sexual and gender minority policies are and gives each state a score. These total scores can range from a negative 17.5, which indicates a very harmful or negative policy environment, to a 38.5, which would be the most protective or most positive policy environment. Through the PRIDE study, we were able to recruit a sample of just over 7,000 participants, and we took these scores to test the relationship to experiences of victimization and discrimination among several different groups within the PRIDE study. So we looked at cisgender sexual minority participants, who comprised about 63% of our sample, gender expansive participants, and these are participants who describe their gender as genderqueer or another non-binary gender identity, but of any sexual orientation. This was 23% of our sample, and people who reported their gender as solely trans feminine or trans masculine spectrum. This was 12% of our sample. Sorry, I forgot I had timing on there. As you can see, total discrimination experiences, we had about 54% of our participant group reported at least some past year discrimination. Our highest prevalence here was in the gender expansive group, and experiences of victimization, just under 25% reported past year victimization, also highest among our gender expansive group at almost 25%. And we look at the results of this analysis, we found that was very counterintuitive to what we expected going into this study. What we found was that more protective state level policy environments were actually associated with greater discrimination among cisgender sexual minority and gender expansive people. We found a similar relationship among protective state level policy environments and past year reported victimization among cisgender sexual minority people and the trans feminine or trans masculine group. This was extremely surprising to us because it's pretty counter to what we know about the intent and the purpose of protective policies. So there were some reasons that we looked at to the broader literature to understand these findings. Recency of legislation is important. It may require additional time before an effect is evident, and this is particularly important and salient among gender minority communities for whom policy protections are relatively recent. There had been, this data collection was in 2018, and there have been considerable sociopolitical changes in considering the rollback of sexual and gender minority protection since 2016. Since then, consecutively over the last 3 years, we have seen a consistent increase in hate crimes directed towards sexual and gender minority people. And there has been an increase in awareness due to efforts of public discussion of legislation. So participants in our sample could be more aware of the struggle for discrimination protections and the increase in violence. And this could make them just more hyper concerned about experiences they may be occurring, but maybe before there was some minimization or some protective coping with harmful experiences. So we're not 100% clear on what's happening here, and this is obviously a correlational design. So longitudinal study will be really helpful to understand the trajectory of people's discrimination and victimization experiences. But these findings were really important and interesting to us. And some implications here, there's limitations to the effectiveness of current policies. Little is known about how policies are actually being implemented. If people feel that they can hold states and organizations accountable to the experiences of discrimination or victimization, that makes the difference as to whether the protections that are in place are actually effective. And we need a better understanding the time to effect and variation therein. So how long does it take to pass a policy? And then how long does it take for individuals in that marginalized community who are intended to be protected to actually experience that change in their life to day-to-day experiences? And there needs to be continued investment and referral to community resources and support. We know broadly in the literature that social support, both familial and outside of the family environment, is important to protect sexual and gender minority people's health and just people's health broadly. So continued investment in these resources is important. This work within the Pride study wouldn't be possible without the broader Pride study team. We have our directors here, Dr. Mitchell Lunn and Dr. Obidin Malaver, and Associate Director, Dr. Anissa Flenchie, who is my doctoral advisor. And this incredible group of people that comprise our staff that work not only in designing and implementing and analyzing our studies, but also interfacing with the community and keeping these community engaged resources and connections going. We have a part of the Pride study is this engagement and continued research and the development of a sexual and gender minority informed research team. So a lot of these folks are also critical to the development of future researchers within the field of sexual and gender minority health. And we also have the participant advisory committee that I mentioned previously. And so these individuals are really important to reviewing and being involved in the studies that are conducted and move forward within the Pride study, as well as evaluating items that are included. A lot of measurement issues exist within sexual and gender minority research. So items that may be used in broader surveys need to be adapted for both use within sexual minority populations and gender minority populations. So both our research advisory committee and our participant advisory committee are critical to being able to review those questions and those adapted questions to make sure that they're desirable for the participants in our study. And then we also have the PrideNet ambassadors. So these are people that help to represent the Pride study in broader social events and interfacing with the community. And these folks are a wonderful group of people that help make the Pride study successful. And I knew I was going to talk too fast.
That's okay. That's okay. No problem.
So I, of course, am on Twitter like all the fun researchers are. And you can also email me at my contact information here. But I'm happy to answer any questions or expand on anything that we've discussed today.
Thank you so much for that. That was fantastic. I have 100 questions for you, but I'm going to start with the ones in the chat. The first question was, your sample's almost 80% non-Hispanic white. Do you have plans to target racial and ethnic minorities in the future?
Yes, this is a huge, huge area of concern. So when you're starting a longitudinal sample, just getting it off the ground is the challenging part, right? And then now that we see that we have this lack of diversity in our sample, this is a high priority for us. So we're actually actively working on engaging with any non-BIPOC populations to understand more about what is going to help incentivize folks to participate, what are barriers to engagement. We're also looking at biological specimen collection and trying to understand facilitators and barriers to that. So this is a high priority for the study at this stage.
What about recruitment itself? How did you recruit participants into the study?
Recruitment was a really diverse effort. So recruitment took place at LGBTQ or sexual and gender minority focused events. Also a broad social media recruitment, a lot of partnerships. We mentioned the collaborative network and the PrideNet, really working directly with community organizations and social supports to work together to be able to recruit the sample was the main tools that we used.
What about retention? You know, I have a question around, I do longitudinal studies as well, and you're lucky if you can maintain 95% of the cohort every year. Do you guys do anything specific to engage participants to increase retention?
So the Pride study is really intended to be this kind of a la carte participation. So we do have a group of folks that do engage in the longitudinal aspect and consistently fill out surveys every year. But that initially, right now, that hasn't been the focus to really encourage retention in a meaningful way. That right now, we're really focused on making sure to build that community aspect to encourage retention. And that is also another area that they're starting to really delve into, what's a barrier to folks not participating regularly? How can we make those community events that we offer as some kind of reciprocal benefit? Like, how can we make those more advantageous? What are barriers to folks being able to engage with those benefits of the Pride study? So it's more exploratory to like, okay, why are we having folks that are not coming back? Like, what's an issue here? Maybe it's our portal system to where it's not easy for folks to change their contact information. Like, we're really kind of exploring those barriers to longitudinal participation, but we face similar obstacles in that as well.
There's great. We've been asking all of our folks when they're coming on this. I'm not sure how much background you got, but we're looking for an endowed professorship here at UAB. We've got the funding. The professorship is specifically around LGBTQ plus health studies. And this is just to get your personal opinion. What do you think we should expect for somebody in this type of position?
Really an understanding that sexual and gender minority communities are definitely not a monolith. Very diverse experiences of differences in ability and racial and ethnic backgrounds and very, very diverse experiences within this community. So I think folks need to be really understanding of that may be coming into that position. And also we need a lot of work done on measurement within sexual and gender minority research. So at a priority for advancing measurement to ensure that we have valid and reliable tools to make sure we're actually measuring constructs that we're intending to measure. Really working on that area is important to the future development of the science within sexual and gender minority research.
I had a question for you, just because you've moved around a little bit. You did nursing in Florida and now in San Francisco. That has to be very different in terms of what you experience day to day when working with colleagues and if you're still working with participants and patients and their own experiences, what you saw in Florida versus what you're seeing in San Francisco. Could you elaborate on that a little bit?
Yeah. So that actually was the whole impetus to my dissertation. So I'm trying to look at different ways that we can understand, we know about structural stigmas, the structural barriers to access to resources and needs within a community, a marginalized community, interpersonal stigmas that those experiences of day-to-day stigma that someone's experiencing. And we have individual level stigma is that someone may be internalizing those experiences. But I think underlying this is really this issue of societal stigma. What are overall community attitudes towards a marginalized group? And in my research, it's gender minority individuals. And I think that has been a major difference between my experiences between Florida, working clinically, and then working in San Francisco, where attitudes were much more warm, accepting. There was less assumption about someone's sexual orientation or gender identity. In Florida, there was a lot more barriers to that. And I found my patients really, really struggling. That was frequently when folks were coming in for crisis stabilization, they weren't coming in because there was something internally wrong with being a sexual minority person or a gender minority person, right? And that's a lot of the assumptions of my colleagues. It was this consistent and chronic stress and rejection that folks were experiencing in our community. And that was not acceptable to me. And I think that is a major underlier of why issues like this policy implementation exists. You can have policies there and they're protective, but if there's no one to enforce them and to make sure the culture changes, there's limitations to that. So really that's inspired all of my work, because we can't improve healthcare environments and healthcare access if we don't fix the attitudes of people who are barriers and facilitators to that care.
Yeah, I totally agree. Do you guys have any kind of participant advisory board with Pride so that you can talk to participants about what they think about the study or what it should be?
Yeah, so that's a regularly conducted part of the Pride study. So we do our listening sessions. So the listening sessions were held really, really frequently in the beginning of the Pride study to kind of get us launched. And now they're held more regularly. So that's also part of PrideNet. So we have the community organizations and also the people that are individually participating in the Pride study who participate in those listening sessions. And then folks are also welcome to communicate regularly about things that they found helpful or not helpful within the surveys themselves. Folks have everyone has a different lived experience. And sometimes, when we're making these surveys, we aren't thinking of that because that's not our position in life, right? Participants have been so communicative about letting us know about their needs or where they don't feel represented. And that's been really helpful to the continued improvement of the Pride study.
Yeah, absolutely. This I know would be really hard because of the model you guys have done with the technology-based surveys or telephone-based surveys, but do you have any plans to try to get people face-to-face to do any kind of a physical evaluation, blood pressure, diabetes, anything like that?
We are working on biospecimen collection remotely. So that's like something, so there's all kinds of technology now, Fitbits and all kinds of things that have potential in the future for that kind of data collection. But we are looking at some current study has been done on biospecimen collection acceptability among gender minority participants, and also looking at the feasibility of actually doing remote biospecimen collection. So that is a future direction that we're looking into within the Pride study.
Great. That must be challenging if you've already got a population that is not terribly trusting of the healthcare system, and now the research system that people don't understand at all walks in and says, "Hey, we want to come see you."
Yeah, the trust issue, I mean, it's a well-deserved criticism we have. I mean, I teach Introduction to Research Methods, and I spend an entire lecture talking about the marginalization of a lot of folks within the research system. I think that is a huge barrier. So respecting and understanding folks why they're not wanting to engage and seeing, like, is that something that we can bridge? Is this an education concern? Is this we need more time to build trust? Like, trying to understand those facilitators and barriers is important and part of the work that we're starting to do. We have a publication, hopefully, that'll be under review soon, that's discussing people's attitudes towards biospecimen collection. We're finding a lot of misunderstanding as to what has DNA in it, what doesn't have DNA in it. And I think this is not so different necessarily from the general public, and a lack of understanding about this part of science, right?
Yeah.
This is something that's ever developing and changing, and it's hard for folks to stay on top of it when it's not your day-to-day job, right?
Exactly.
So yeah, understanding how we can better engage with folks. And I think the cool thing that Pride Study does is these active engagement pieces where we can have dialogues with our participants. We've also utilized video and other types of media to educate participants. They're working on some video consent options so that folks can watch something instead of having to read something. Anything we can do to make things more accessible and better understood for participants is important.
Yeah, that's great. We have another question from the audience. Is there any kind of additional incentive for participants to be a part of the study?
Sometimes there are paid participation depending on the ancillary study and the amount of involvement. So some qualitative studies they have. So what happens is that you register in the Pride study, and you're in the pot, you get these annual surveys. And then if someone is doing that ancillary study where they're doing a different kind of data collection, you meet the criteria for who they're looking for to participate, you'll get contacted. And frequently for those ancillary studies, there are incentives.
That's great. What about geographic differences? Do you think you have any kind of geographic differences in terms of willingness to participate, since a lot of the outreach that you do is through community groups?
Yeah, and this is something, so we do have our sample. I was just looking at this for part of how I'm analyzing for my dissertation, but our sample still is predominantly urban. And I think there's a lot of reasons for that. We do have a broader population instead of just from the urban bases, where most of the established science is from urban city centers, right? The current science from sexual and gender minority health. Rural communities continue to be really difficult to access. And when you think about it, for folks that I interviewed for one of my qualitative studies for mental health access and barriers, a lot of folks had come there from a million different places across the United States. I was talking to folks that had been hospitalized across 10 different states across the country before they got to San Francisco. Folks go where they feel safest and they feel that there's a community to support them. So I think that that's part of the population being broadly living in urban environments. But yeah, there's a need to delve more into rural communities and to really focus on how we can diversify the sample that way. We're capable, the infrastructure is there. Really looking at how to invest those communities is important.
Well, this has really been fantastic today, Kristen. I've been following the Pride study for a long time, watching. I think it's so important that we do longitudinal research and allow folks to participate if they're interested, but it's just a group that we have not included in longitudinal studies. And so it's so exciting for me to see the work you all are doing, and I'm going to continue to follow what you're doing. I can't wait to see the results of your dissertation.
Yeah, it'll be out there eventually. I've been feeling very, very privileged to be a part of it. It's a great group of people that are really invested in not just the community, and also investing in researchers that are supportive and doing the right thing with the community. Also, queer peer mentors, and also having researchers that are part of the community. Like, this is all a great investment for the future of sexual and gender minority health. And I'm just feel very lucky to be here and also a part of the study.
Yeah, absolutely. Well, thank you for being here with us today. It's been great chatting with you, and we look forward to talking to you again someday soon.
That sounds great. Thanks for having this facilitated, and I appreciate the opportunity.
Absolutely. Absolutely. Thanks everyone for attending.